a Sunday evening, everybody gathered to listen from a speaker. So it's a great pleasure and honor for me to deliver this session on how contact lens induced dry eye can be diagnosed, what is the etiology behind it, what are the signs, symptoms, and how do you go about managing so as to successfully fit contact lenses without any dropouts because of a dry eye situation, right? So yeah, why this topic matters is the single largest reason for why contact lens dropouts happen is because of dryness and discomfort. And what is the cause for dryness and discomfort? Obviously, the dry eye situation. So 20 to 50% of contact lens wearers world over discontinue lens wear at some point or the other. So it is a leaky bucket situation, I would say, that with new designs, innovations, people are wearing contact lenses more so now, but then an equal number of people are also dropping out significantly, which means it is balancing out, and the number of contact lens wearers, approximately 110 million wearers, remains the same over a past decade or so. So many dropouts can be prevented with better screening, better lens choice, and proactive dry eye management. So the key message here is dry eye and contact lens practice are not separate. They must be integrated into each one's practice. Now, let us look at the vicious cycle of dry eye and contact lens wear. So, if you look at when somebody wears a contact lens, what happens is invariably, no matter how best the design is, how best the material is, what happens is there is a disruption in the tear. Okay, it splits the tear film as to the pre-lens tear film and the post-lens tear film. Okay, and with this tear film disruption causes hyperosmolarity. The salt content of the tear film increases, and because of this, there is an inflammatory reaction. Okay, there is an increased amount of cytokines and inflammatory agents in the tear film, and because of the increased inflammation, what happens? There is surface damage of the ocular surface, and when there is any surface damage, that will induce discomfort. And what happens when somebody is wearing contact lenses and experiences discomfort? They will try to reduce the wearing time. Okay, so when a patient wears for a first time contact lens wearer, so they'll come to you saying कि शुरू में मैंने 6-7 घंटे अच्छे से पहने थे, बहुत आराम था, बट धीरे धीरे मैं ना इतने घंटों तक पहन नहीं पा रही हूँ. लाइक फॉर इंस्टेंस, पहले मैं 10 घंटे पहनती थी, तो अब मुझे लग रहा है कि 5-6 घंटे के बाद पहना नहीं जा रहा है. Then the next stage will come where they will say कि मुझे इतना तकलीफ हो रहा है कि जब मुझे चाहिए होगा तभी मैं कॉन्टैक्ट लेंसेज पहनती हूँ. मतलब वेरी सेलेक्टिव. अगर कहीं मुझे बाहर जाना है, कोई फंक्शन अटेंड करना है, तभी मैं लेंस पहनती हूँ, वरना मैं पूरा दिन पहले जो शुरू में पहनती थी वो मेरे से पहना नहीं जा रहा है. एंड देन एक सिचुएशन आता है कि वो चंद घंटों के लिए भी पहन नहीं पाते लेंस, एंड व्हाट हैपेंस इज इवेंचुअली अरे छोड़ दो, लेंस ही छोड़ दो पहनना. सो दैट रिजल्ट्स इन अ ड्रॉप आउट. सो दिस इज अ विशियस साइकिल. व्हाट हैपेंस व्हेन समबडी वेयर्स अ कॉन्टैक्ट लेंस? कैसे एक टीयर फिल्म डिस्टर्ब होता है? Because of the disruption, there is a cycle of reactions. A chain reaction happens, which leads to discomfort. Eventually, it hits on the wearing time of a contact lens wearer, and then they drop out of contact lens wear. I have a quick question to the audience. Is it okay that I mix Hindi and English, or you want me to speak only in English?
No, ma'am, it's okay.
Okay, fine. Thanks. So, before I go into saying contact lens dry eye or contact lens induced dry eye, there are two things that all of us need to understand, the terminologies. One is contact lens induced dry eye, and which is CLIDE in short. Another one is contact lens associated dry eye. इन दोनों में फर्क क्या है? When I say contact lens induced dry eye, इसका मतलब है जब contact lens पहनते हैं तभी dry eye situation पैदा होता है, बट कॉन्टैक्ट लेंस नहीं पहनेंगे तो दे आर एब्सोल्युटली फाइन. जैसे मैंने बोला, कॉन्टैक्ट लेंस डिस्टर्ब द टीयर फिल्म, चेन ऑफ रिएक्शन होता है, डिस्कम्फर्ट होता है, और इवेंचुअली दे ड्रॉप आउट. तो ड्रॉप आउट मतलब बिना लेंस के बहुत उनको आराम मिल रहा है. those are the people who have contact lens induced dry eye. Now, what is contact lens associated dry eye? These are the kind of people who already have dry eye and symptomatic regardless of contact lens wear. मतलब उनको पहले से ही ड्राई आई था, आपने कॉन्टैक्ट लेंस पहना दिया उसके ऊपर, आपने मैनेज नहीं करा, एंड नाउ दे हैव dry eye signs and symptoms with contact lens even after they not wear contact lenses. But after contact lens removal, the Clyde वाले patients जो हैं उनको काफी फर्क पड़ता है, मतलब they are comfortable without contact lenses. But Clyde वाले जो patients होते हैं, they are symptomatic even after cessation of contact lens wear. That is the difference between Clyde and Clad. Now, talking about contact lens induced dry eye or Clyde in short, this is a condition where contact lens wear disrupts the tear film. जैसे मैंने पहले बताया, it disrupts the tear film as well as the ocular surface, which leads to dryness symptoms. So, mechanism क्या है? The same mechanism. There is a destabilization of tear film. There is increased evaporation of tears. There is reduced tear volume under the lens, या लेंस के पीछे जो वॉल्यूम ऑफ टीयर्स होता है वो बहुत कम है, बिकॉज ऑफ विच देयर इज अ लेंस डिहाइड्रेशन सिचुएशन, एंड उससे ज्यादा फ्रिक्शन होता है, लिड वाइपर रीजन पे स्ट्रेस ज्यादा पड़ता है. सो यू विल फाइंड, सॉरी, यस
मैम, जो आप इंग्लिश में कंटिन्यू करिए क्योंकि बहुत पार्टिसिपेंट है मैसेज कर रहे हैं.
ओह ओके, सो फाइन. Right, I'm absolutely fine with that because I want to ensure that whatever I communicate reaches to the audience. There's no point if I speak in one particular language and the audience are not able to connect with me, then there is a problem. So I always clarify. Good that you guys have message saying that you want me to speak in English. So I'll continue in English. So what I'm talking here is about a situation called Clyde, or a condition called Clyde, which is contact lens induced dry eye. Now, by definition, if you say what Clyde is, Clyde occurs when the tear film and the ocular surface is disrupted because of contact lens wear, which leads to dryness symptoms in the wearer. Now, what is the mechanism behind Clyde? If you've noticed in my previous slide, I demonstrated the vicious cycle behind the Clyde development and eventual contact lens dropout. So, what happens first is there is destabilization of tear film. There is increased evaporation. Why that happens? Because of the hyperosmolarity of tears. Okay. Then there is reduced tear volume beneath the lens. Then lens dehydration situation occurs, because of which there is increased friction in the lid viper region. There is so much of stress on the lid viper region that it leads to lid viper epitheliopathy and a subclinical form of inflammation which becomes clinical eventually. So there is a whole bunch of mechanism that is involved in contact lens induced dry eye. Now, if you talk about the prevalence of contact lens induced dry eye, it is variable. Again, nobody is too sure whether it is purely Clyde or it is a pre-existing dry eye wearer which has led to aggravated situation. So there are very many variations in the prevalence. Also, the tests that are used to diagnose Clyde is not uniform throughout because of poor understanding amongst practitioners also. So why is this huge variation? Because of different study population in the published studies, the variance in the contact lens material that has been used in people who are experiencing Clyde, and the variability in the diagnostic criteria. Some could be self-assessment or based on symptomology questionnaire, and also the variation in the clinical tests that are used to confirm a Clyde. Okay. Now let us look at what are the risk factors which lead to the development of Clyde. So there are three pillars rather. So first one is contact lens related factors. Second is the environmental factors, and finally the patient related factors. Now let us look at what are the contact lens related factors which are high risk for development of Clyde. So it is noticed that soft contact lenses wearers rather than rigid contact lens wearers have an increased risk of developing Clyde. And amongst the soft contact lens wearers also, hydrogel contact lens wearers have an increased risk for developing Clyde. Again, high water content lenses, lenses with poor wettability, and also people who are having increased wearing time. All these are situations which lead to the development of clyde. Now, what are the environmental factors? Increased temperature with reduced humidity and prolonged use of visual display units, digital gadgets, they are more prone to development of clyde. So these are contact lens wearers who are working in such environmental conditions, which most of the cases nowadays we come across. Now, coming to patient-related factors, these published studies so far and all the research and reviews, they point that females are more prone to developing clyde. Asian population are at more risk of developing clyde. Rigid contact lens wearers, especially people who already have 3 and 9 o'clock staining complication, corneal dilin that is noticed in rigid corneal lens wearers, or these people are at increased risk of developing clyde. I did mention that soft contact lens wearers um, predominantly have a risk of developing dry eye. That doesn't mean that rigid contact lens wearers do not develop clyde. They also have in a possibility of developing clyde. Is just that soft contact lenses wearers are at more risk than rigid lens wearers. But again, if a rigid contact lens wearer already has developed a complication like 3 and 9 o'clock staining, and which the practitioner has ignored, then they have increased chances of leading to a clyde. Also, in soft contact lens wearers, if you notice inferior closure staining, what is inferior closure staining is when you remove the soft contact lens and you stain the eye with fluorescein and you observe under the slit lamp, you will notice that the inferior region of the cornea or the conjunctiva picks up the stain, which means that their blink is not complete. They're all partial blinkers. They wear contact lenses, but they're not complete blinkers. So because of impartial blinking, the lower region, exposed region, is undergoing desiccation, and that desiccation leads to picking up of the fluorescein dye when you use fluorescein. So that is the inferior closure staining. I'm sorry, I'm not sharing a clinical picture. I think I missed on that. So let us see what happens to the tear film without the contact lens and with the contact lens in situ. So the left image that you see is the regular tear film, which comprises of the lipid layer, the intermediate aqueous layer, and the mucal or the mucin layer. But when you're wearing, somebody wears a contact lens, say for instance a soft contact lens, you look at this right hand image. I don't know, I can use a laser pointer. So you see this region which I am directing, that is a soft contact lens. So it is roughly around 70 microns, okay? And that splits the tear film into the pre-lens tear film and the post-lens tear film. So if you look at this thickness, the entire thickness of the tear film gets split into two, the pre-lens tear film and the post-lens tear film, which is around roughly 2 to 3 microns. Okay, so this is what happens. So the mechanism is, the core mechanism of clyde involves the partitioning of the tear film into the pre and post contact lens films. Now tear film thinning and a decrease in overall tear volume and its stability happens, and this leads to increased evaporation of the post contact lens tear film and decreased contact lens and ocular surface wettability. Of course, there is increased tear osmolarity and ocular surface inflammation. If you recollect the vicious cycle that gets involved in the clyde mechanism, and also clyde is associated with increased prevalence of meibomian gland dysfunction, because of which there is a less of the lipid layer of the tear film which is secreted, which leads to eventual quicker evaporation of tears. So there are so many factors which contribute to the development of clyde in a contact lens wearer. Okay, so far is it good? All of you are being able to follow until now? Can I get a response, because I can't see? Sorry. Can someone help me? Anik or Manak?
Hello.
Yeah?
Hello.
Yeah, I can hear you. Go ahead.
Yes, ma'am. I didn't hear you.
Yeah, I hope the audience is with me. because I
Yes,
can't
ma'am.
see.
Yes,
Okay. Yeah, right. Thank you. So let us look at couple of signs and symptoms. So for me as a contact lens practitioner and a person who handles the dry eye clinic, also for me I won't say that Clyde is very unique and it has a different identifiable set of signs and symptoms. More or less the signs and symptoms are typical of any other regular dry eye case that I see in my clinic. Nevertheless, when you look at a person who is wearing contact lenses, then you go by a set of signs and symptoms which should take you or direct you towards future case of Clyde. Even if they do not have, then it should be able to trigger that thought process in you. So coming to the signs of Clyde, you will notice that the person has a reduced tear breakup time. So again, how do you measure the tear breakup time is very important. So the Tear Film Ocular Surface Society recommends that you measure the tear breakup time non-invasively. That is most preferable. Okay, and when you're using a non-invasive tear breakup time, the cutoff is 10 seconds. But when you instill fluorescein, the cutoff becomes 5 seconds. So you need to understand the clinical cutoffs to be able to know that this person has a definite reduction in tear breakup time. Of course, then you go by the decreased tear meniscus height, the corneal epithelial staining, increased blink rate. Now, don't get confused that, I just mentioned a slide ago that, they blink impartially. Now, blinking several times and blinking impartially are two different entities. You may be blinking, the normal blink rate we say is 15 to 70 blinks, 17 blinks per minute. A person could be blinking even 20 times a minute, but if they're not blinking completely, it is of no use. So I really do not, kind of concentrate much on the blink rate. I'm more interested in the completeness of the blink. I would, look at how full the blink is, okay, to give me more idea. And then, of course, tear hyperosmolarity. You can use the tear lab, which is a small piece of equipment. You withdraw the tears with a pipette and then you measure the osmolarity. Of course, in a clinical setting, if this is not possible, good in a lab setting where a lot of research happens in the tear film. Okay, so nevertheless, if you have access to a tear lab, you can check for tear hyperosmolarity. It would be fantastic. And of course, ocular surface inflammation. You can there are certain biomarkers for ocular surface inflammation. That increased amounts of MMP9 or cytokines indicates that there is increased inflammation on the ocular surface. Coming to the symptoms, there is reduced visual acuity, there is foreign body sensation, dryness, eye strain, blurred vision, and discomfort. So let us look at the diagnostic test to assess Clyde. First, most importantly, is the history. History is a base for anything. Even in a general optometry practice, you cannot ignore the importance of history. History itself will give you loads of ideas and it will, narrow down as to next set of tests what you need to do based on a thorough history. So that should include your general medical history, ophthalmic history, and risk factor identification. We did go through the couple of slides on individual risk factors. So that should be in your mind whenever you are probing and asking those related questions. Of course, next is the symptoms. So subjective assessment by using validated questionnaires. There are plenty of symptomology questionnaires that are available. So the preferable ones would be the CLDEQ 8 questionnaire or the OSDI 12 or 6 questionnaire. Again, for each of the questionnaire that you use, you need to understand the cutoffs. So a score of more than or equal to 6 in a CLDEQ 8 questionnaire is meaning that it is positive for symptoms. A score of 13 and above in an OSDI 12 questionnaire and a score of 4 and above in an OSDI 6 questionnaire means that the patient is symptomatic for dry eye. So symptoms are very, very important. If the patient is asymptomatic but presents with signs of dry eye, that doesn't mean that person has dry eye. That is something else. So you need to understand. Again, the patient is symptomatic but clinically nothing is visible, then that is also not dry eye. So to confirm that the person has dry eye, the person has to be positive for symptoms as well as for signs. Okay, so remember this is a very important point. Now, coming to the objective clinical assessment. So, you need to assess the cornea as well as the conjunctiva, which form the anterior ocular surface. So, staining, look for staining on the cornea as well as the conjunctiva. So, liberally use fluorescein dye as well as lissamine green dye. Okay. So, the corneal epithelium, it stains well with fluorescein dye, and the conjunctival epithelium stains well with lissamine green, which you can observe under the white light of the slit lamp. Okay. And then you have the lid parallel conjunctival folds, which are also indicators for moderate to severe cases of dry eye, which you look for over here. So this is the area where you will look for the lid parallel. These are parallel folds of conjunctiva which bunch up. That is indicative of dry eye. So I don't know if this picture is visible clearly to you guys, but if you look at the base where these two beams of light meet, you can see couple of folds of conjunctiva. So this is the lid parallel conjunctival folds, or the lip cough in short. Okay. Now comes very important evaluation of tear film. So if you want to look at the tear film composition, osmolarity testing is definitely recommended, and tear film ferning if you have access to it. Tear film ferning and osmolarity is predominantly done in research and lab settings. Okay. Now talking osmolarity testing is just to test how much of milliosmoles of salts are present in a drop of tear. Okay. The cutoff is, 308 is the upper limit. Beyond that, meaning there is increased amount of salts present. Okay. And also the interocular difference of 8 milliosmoles means that it is a hyperosmolarity condition. Okay. And then tear film ferning, again take a drop of tear, spread it on a glass plate and observe under the microscope. So a regular tear film, when you tear drop, when you observe under the slit lamp, this will give you a very uniform fern pattern. If you know what a fern plant is, look at the leaves, it will be spread out evenly. So that kind of picture, that is called tear film ferning. But in dry eye, you will notice that no clear pattern is formed. It is all fragmented. So this is how you look for tear film ferning. This is observed under the microscope. Okay, not the slit lamp biomicroscope, with the regular, compound microscope which we use in our labs. Then you checking for the tear film volume, you can assess the tear meniscus height. Then the tear production and secretion by the Schirmer's test or the phenol red test, thread test. Tear film stability you can find out by the tear breakup time, or the non-invasive tear breakup time, which is recommended. Lipid layer thickness by interferometry or tear scope, and ocular surface evaluation by the corneal and conjunctival stain. Now coming to assessment of eyelids, very important to look at the lid viper region. Again, how will you assess the lid viper region? By using a dye called lissamine green. And again, you need to follow the Cobb scale for lid viper epitheliopathy grading. Okay, grade 0 meaning only the marks line gets stained, whereas grade 1, 2, 3 indicates mild, moderate, and severe cases of lid viper epitheliopathy. Meibomian gland assessment is done. Look at the lid margin where the meibomian gland orifices open. So sometimes if you notice, these are capped or blocked orifices, which means that lipid production is inhibited because of the blockage of these orifices. So simple thing is giving hot fermentation and then expressing this with using a forceps. That is highly recommended. So when you notice that patients already have this pre-existing condition, then when you go about giving them or dispensing contact lenses, then it becomes a case of Clyde and eventual dropout. They will never again wear contact lenses in their life too. An assessment of blink rate and completeness. More than blink rate, I would prefer that you look for completeness of blink. The upper lid margin should touch the lower lid margin. That is complete blink. Okay, apart from checking or assessing the amount of blinks a minute. Laboratory assessments, that is to find the inflammatory biomarkers like the matrix metalloproteinase, MMP9, mRNA, cytokines, and chemokines, which are in increased concentration in the tear film when there is ocular surface inflammation. That is a late biomarker, I would say, not in the initial stages. Okay, and assessment of mucin function and goblet cell density, again you can do. Lissamin green again is a good dye which you can use to, when the conjunctiva stains exhaustively, that is an indication of, disruption in the mucin function. And impression cytology can also be done to assess. But again, all these for research purposes and lab settings. In regular clinical practice, we definitely do not do all of these, right? Now, what are the symptoms that you should be alerted upon? So, typical patient complaints are, comfortable in the morning, but the eye feels dry by evening. The lens feels stuck onto the eye, or the vision fluctuates. It's not, really uniform. There is a burning sensation after I remove lens, or I need to blink frequently, or there is increased amount of watering with dryness. So the red flag is end of the day discomfort itself means this is a very classic Clyde symptom. Always remember, shuru mein theek hai and then it gets bad by the end of the day or worse by the end of the day indicates Clyde symptom. So the top reasons for lens failure is ignoring meibomian gland dysfunction. This is singularly the most commonest reason for, lens failure. If you have ignored managing meibomian gland dysfunction, fitting lenses without a proper tear film evaluation, or wrong, prescribing the wrong lens material or modality. And of course, there is poor compliance from the patient's end. They're not replacing lenses as scheduled and using, solutions which are not compatible with the lens material. And they're over wearing the lenses also. If the recommended wearing time is 10 hours, sometimes people end up wearing it for even 16, 17, 18 hours. They're over wearing the lenses. So that could be also another reason for lens failing, and not addressing screen related blink issues. Now, what is a clinical screening or the golden rule is to treat the surface before you treat the refraction. Okay, so the pre-fit screening checklist should include the symptomology questionnaire that I mentioned earlier. Either you use an OSDI 12 or 6 questionnaire, or CLDEQ 8 questionnaire. So always remember there are plenty of questionnaires, McMoney's questionnaire, for example, or speed questionnaire or SAND questionnaire. There are plenty of them. And different questionnaires have different number of questions. The more the number, the more irritated the patient feels. Nobody wants to go through, hundreds of questions or 20 questions, 25 questions sitting, because they come to you with a problem and they want a solution. They don't want to keep sitting and, tick marking, things that, you're asking, and they may not even be interested in it. So always a tip that I should say is use a questionnaire which a validated questionnaire which has the shortest number of questions to get the correct answers from the patient. Okay, they can be seated in the, outpatient department waiting to enter the clinic. Before that, you can run these questionnaires. So before they reach your desk, you can have the symptomology score in front of you. Then assess the tear breakup time. That's the simplest thing that you can do. Tear meniscus height. All these doesn't require any expensive gadget to be invested upon. And of course, meibomian gland assessment with a slit lamp examination, you can know. Corneal and conjunctival staining, again, just a slit lamp with the fluorescein and lissamine green, you can stain the ocular surface. Lid viper evaluation, again under the slit lamp. Blink rate and completeness, again, direct observation. And mybography, if you have access to a mybographer, then nothing like that. But since if you're starting early, you don't have to invest in that. Like I said, all of these tests that I mentioned doesn't require any fancy gadget. All that you need is, use validated questionnaires and have a very good slit lamp. If you have a video slit lamp to, record all these signs, clinical signs, and create folders, so that when they come back to you after 15 days of management, you know how the condition has progressed or regressed. So that is very important. So photo documentation, video documentation is very important. So if at all you invest in a slit lamp, look at investment in a video slit lamp. Okay, and later when you see that you have a good volume of patients and your practice is growing, then it's always advisable that you invest in a micrographer also, and it's readily available everywhere. So the minimum test that every clinic must do, especially where you're fitting and dispensing contact lenses, is to run a quick dry eye workup, which barely takes 3 to 5 minutes. It's not some extra set of half an hour or 45 minutes that is going to eat up patients' time. So symptom score. See, there are certain things that I keep repeating, not because I love repeating, it's just because I want to reiterate that how important these are and how you cannot ignore these simple things like running a symptomatic score, slit lamp evaluation, the lid margin evaluation, assessing the tear breakup time, fluorescein staining, glycemine green staining, meibomium gland expression. So the simple rule is if tear breakup time is less than 10 seconds, okay, and you expect that the discomfort risk is going to be very much prevalent. So if you have to understand dry eye in contact lens wearers, there are evaporative dry eye because of rapid tear evaporation, which is most frequent cause. Aqueous deficient dry eye results from insufficient tear production. Here, it is very direct again because there is less of aqueous production, there is less volume of tears. So you need to aggressively manage this by giving artificial tears to increase the volume of tears. And if it's a contact lens wearer, something that is compatible with contact lens wearer. I'm going to talk about it in the next coming slides. Frictional dry eye arises from irritation between the lid and the cornea. Why there will be increased friction? Because the lens gets dehydrated. Because of dehydration, there is more friction between the lid and the contact lens surface, and that causes desiccation in the lid viper region, leading to lid viper epitheliopathy, then discomfort, and eventually dropout from contact lens wear. And then there are a set of allergy driven discomfort. This is because of allergic reactions either to the solution or to the contact lens materials per se. So again, you need to identify what is causing this discomfort. So discomfort, you cannot really club everything together. So if you have to manage something, you need to identify what is causing the discomfort. So you have to work in all of these areas. So the modality decision table is if you notice that somebody has meibomium gland dysfunction and there is a quicker evaporation of tears, so and you have managed them, but there is a tendency for them to develop, meibomium gland dysfunction. The best lens choice would be daily disposable silicone hydrogel lenses and a lipid-based artificial tears. If they have an allergic situation, then obviously daily disposables. Avoid monthly deposits in a monthly wear lenses. Low tear breakup time, so you can recommend a water gradient contact lens which has high wettability. Heavy digital usage people, it's always good to go in for daily disposables and blink training or blink exercises. And solution, somebody who has sensitivity to solution, again daily disposables, or recommend peroxide system. Again, it is not readily available in our country, so the preference would always be a daily disposable. And somebody who are heavy depositors, some people get too much of deposits on their lenses, then always recommend daily disposables. So if you notice, majorly in this table the recommendation is daily disposable. You can say that, but daily disposables are super expensive. But if you weigh the pros and cons, the amount of time, energy and money that they will spend in maintaining these other lenses with solutions, case maintenance, you can do away with all of that. You can work about the economical part of it by telling or comparing and counseling the patient that they can get away with not maintaining any cases for that matter, or investing in solutions and all of that. And daily disposables are the best choice for them. So a comprehensive contact lens care, you need to understand that daily disposables are a convenient option with regards to hygiene and comfort. Solution induced dry eye is because of dryness caused by improper solution usage. Then there is something called preservative toxicity, which is because of the harmful effects of preservatives in solutions. So always notice the bottle, the ingredients, what is the preservative. Of course, now the latest solutions, they are mostly compatible with both silicon hydrogels and hydrogels, and the preservatives are no longer what it used to be in earlier days, like back or something like that. Then poor cleaning habits, so inadequate cleaning leading to infections also. Topping up solution is again a bad habit of patients, non-compliant patients. They either forget to throw away the solution present in the cases, or simply try to, already the case would have, remainder solution from the previous day, and then they top up, pour extra fresh solution into it. So that is like adding fresh solution to the old solution. That also ends up in conditions where infections develop. There is a biofilm which develops in the lens case, and that is going to lead to infections also in the eye. So biofilm build up because of accumulation of microorganism on lenses. Why? Because they are used to topping up solution. Okay. Hydrogen peroxide system is effective in cleaning without any harsh preservatives. Again, in our country, this has been discontinued for now. Hopefully, we get them back. And you can generously recommend preservative free systems. So these are solutions without any preservatives, especially for sensitive eyes, and lot many brands do have preservative free multi-purpose solutions. So the role of MGD, that is the hidden culprit in most of the contact lens wearers, that you need to find out by the science, and also manage. Warm compress, lid hygiene, in office, at home therapies can be recommended. Omega 3 supplements are very good. And then of course you have IPL therapy or thermal pulsation therapies that can also be aggressively managed with. So the dry eye management plan is, you need to treat the patient for dry eye first and then think about fitting lenses later. So you need to stabilize the ocular surface by actively going in for lid therapy, lubricants, reduce the inflammation and treat allergy if present. So in such cases, daily disposable lenses are preferred for dry eye conditions, and regular follow-up and compliance reinforcements are very, very crucial. Okay, so this is to retain your patients. Okay, this is very, very important. So, coming to artificial tears, what works with lenses? What are the pros? Better to go in for preservative free artificial tears. So, whenever you're recommending artificial tears, always notice that they are preservative free. Of course, the preservative free artificial tears are slightly more expensive than the preserved artificial tears. Then, hyaluronic acid based artificial tears are very good. And then also see if the artificial tear is compatible with contact lens. There are certain artificial tears which are recommended with contact lenses on the eye, and some are recommended after removal of contact lenses or before wearing the contact lens. And lipid containing artificial tears are very good because it keeps the oil layer intact and prevents quick evaporation of tears. So, what is not recommended is preserved drops and frequent use of preserved drops. Okay, drops I mean is artificial tears. Then managing digital dry eye in lens wearers. So what are the causes of digital dry eye in lens wearers? Because of quick evaporation, there is a reduction in blink rate because of increased screen usage. Environmental factors, they usually end up working in dry environments where the humidity level is low. So you can recommend desktop humidifiers which are readily available on Amazon. Then adjustment of the screen height, ergonomics, you need to look at, ask them where have they placed the screen, how high it is or how low it is. So you need to do an ergonomic evaluation, and also ask them for the lens wearing habits, whether they're taking any frequent breaks and what is the lens care system that they're using. So the clinical recommendation, of course, all of us are aware of the 2020 rule. So this is not practical in most cases. Even we get engrossed hours working on the system and we forget about the 2020 rule. So you can tell them, or keep some timers, take frequent breaks, and recommend blink exercise. Even if they're not able to follow the 2020 rule, ask them to go in for simple blink exercises. Okay, so Inflammation, again, I told you, not everybody goes into an inflammatory reaction. That is slightly in moderate to severe cases of dry eye, you see inflammation. So low levels of inflammation, when you notice, you monitor closely when there is persistent staining or conjunctival hyperemia or chronic symptoms. High inflammation requires aggressive treatment. Of course, they will have to be managed by an ophthalmologist where there is involvement of steroids, cyclosporins, liftigraft, and allergy control. So, when there is no medical therapy required, when the symptoms are chronic and you need to keep a watch on them, and you can recommend a change of lens also. So again, to wind up, a step-by-step clinical workflow will involve history taking plus a symptomatic, questionnaire, lid margin evaluation and meibomium gland assessment, tear breakup time and staining, and decide if you need to treat dry eye first and then fit contact lenses. Then you have to choose what kind of lens modality is most appropriate for your patient. So daily disposable is the first choice, even if you notice there is mild signs and symptoms of dry eye. Teach hygiene and the wearing schedule, and follow up in 1 to 2 weeks if it's a neophyte contact lens wearer. Reinforce compliance and reassess tear film during every follow-up visit. Okay, I'm going to go through a quick case study for you to understand better. So this is a case of a 60-year-old female lawyer who has a screen time of 4 to 6 hours a day. The eyes feel dry, burning, itchy near the outer corners. Uses artificial tears, whatever is available or the cheapest in the market. She just uses twice or thrice a day. She used to wear contact lenses, but no longer wears contact lenses because of discomfort. Her health is good. She's not on any medication. She's a non-smoker. She wears eyeliner or mascara occasionally. So this is the case about. Coming to the clinical findings, the best corrected visual acuities were 6.6 N6. OSDI 6 questionnaire was a score of 5 uh, on a possible score of 24. So you understand that the cutoff for OSDI 6 is 4, which means 5 meaning that she is symptomatic. Non-invasive tear breakup time was 7 and 6 seconds. Again, the cutoff was 10 seconds. Tear meniscus height 0.3 mm and 0.3 mm. Lids and lashes noticed Demodex blepharitis. Cornea was clear. Conjunctiva showed some lid margin staining, which was lid viper epitheliopathy grade 2. Mybography grade 0, which means that the glands were doing great. So if you look at how do you go into confirmation of a dry eye on the symptomology questionnaire, she was symptomatic. It was 5 out of 24, which and the cutoff is 4. So she was symptomatic. So non-invasive tear breakup time was also positive. We did not do osmolarity checking. So we went for ocular surface staining. Noticed that the lid margin was staining for lid viper epitheliopathy. So we noticed that she had a tear film deficiency as well as eyelid abnormalities. So management and therapy comes after a proper diagnostic test has been confirmed. So this is a case of dry eye disease. So management of reduced tear breakup time and lid viper epitheliopathy with artificial tears with a combination of ingredients. I mentioned combination because they work best for such cases. So there are artificial tears which has only one component in it or one ingredient in it, like um, CMC based thing or just a hyaluronate based artificial tears. But when you have a combination of CMC and hyaluronate and polyethylene glycol, such combination artificial tears are also available. So it is highly recommended for such cases. Now again, it depends which case goes well with combination of ingredients in artificial tears. So that was recommended for twice or thrice a day for close to 2 to 3 months, because we noticed Demodex blepharitis. Tea tree oil based lid hygiene and device driven options were provided to her both in office and at home therapies. Lid wipes which has tea tree oil were recommended for her for a period of 15 days, and post that she was doing great. Omega 3 oral supplements were recommended, blink training exercises were given, and follow up after 2 weeks. So this is the case of So the follow-up visit, we noticed that the OSDI score significantly dropped to 3, which was well within the normal. Tear breakup time also increased. The tear stability increased from, I think 6-7 seconds to 11 seconds. Lid viper epitheliopathy from grade 3, or maybe it remained at grade 2 because it takes longer time for lid viper epitheliopathy to get normalized. So the management was to continue the same management protocol and review after 1 month to discuss the contact lens wear resumption. So that is very important. Remember, she was a contact lens wearer and she was trying different artificial tears, because they are available over the counter. Some friend mentioned something, some relative mentioned something, so people try experimenting. So once they come to you, how you go about assessing each and every aspect, identify which layer of the tear film is at a problem, and then recommend the right artificial tear. That is very important. And then when a person needs to stop lens wear temporarily, when there is significant corneal staining, recurrent infiltrates, or severe meibomian gland flare, allergic conjunctivitis, or contact lens associated red eye. So the rule is always to treat first and refit later. So follow-up schedule is to prevent dropout. So very, very important. In the first week, you fit the check, symptoms and compliance. First month, you look for staining and clear breakup time assessment. 3 to 6 months follow-up, you evaluate the lids and reinforce the compliance measurements. So the key take-home messages from today's lecture is to fit successfully without dropouts, screen every contact lens patient for dry eye. Meibomian gland dysfunction is the biggest hidden cause for contact lens discomfort leading to dropout. Daily disposables reduce complications drastically. You manage the environment and the blink behavior of every patient that you come across. Treat inflammations early, and follow up is as important as fitting of a contact lens. So, to conclude, successful contact lens fitting in dry eye is not luck, it is protocol based practice. So, I wish each one of you a great practice, and please do keep in mind that dry eye is a very important factor that you need to consider in every not just contact lens patients, but every patient that you come across nowadays have dry eye. So you cannot ignore dry eye. You have to confirm first whether it is a true dry eye by running a questionnaire and looking at the signs of dry eye. So thank you so much for your patient hearing. I hope this session was useful to each and every one of you. In case you have any further doubts, you can ask your questions or you can mail me. I'll try and get back to you. So thank you so much.
Thank you so much, ma'am, for joining.
Yeah. If, are there any questions?
Good evening, ma'am.
Yeah, good evening.
Ma'am, what are the questions there are asked in a questionnaire?
So different questionnaires have different set of questions. So I can't definitely discuss about what questions. So typical like OSDI 6 questionnaire would ask in the past 1 month, have you felt too much sensitivity to light? They will ask, is it very frequent? Is it occasional? Is it never? So they're given options like that. They have to tick that relevant option, right?
Okay, ma'am.
Yeah. So these questionnaires are readily and freely available. You can just Google for OSDI 12 questionnaire, OSDI 6 questionnaire, contact lens dry eye questionnaire, CLDQ. Okay, so all these questionnaires, you just Google that, download that, take printouts, and run those questionnaires. Some will say recall period, past 1 month, how many times did you feel watering of the eyes, or where you couldn't work on the system for a long time? Such questions. Is it sometimes, very frequent, like that?
one more question, ma'am.
Yeah.
Ma'am, what are those blinking exercises you are talking about?
So what I recommend for my patients is I just tell them keep one finger in front of you. You don't have to look at farthest distance. Just look at your finger. Close your eyes. Count 1, 2, 3. Then open. Then again close your eyes. Completely close your eyes. Count 1, 2, 3. So do this 10 to 15 times, how many ever times in a day you are able to manage. So recommended is at least 3 to 4 times in a day. So these work like a magic actually. So this is a simple blink exercise that you can do. Then there are so many things which come online also. You can type blink exercises, but I prefer not something which are digital gadget based. So I prefer something simple like look at your own finger, close your eyes, and just count 1, 2, 3 or 1, 2, 3, 4, 5. Not fast, not too slow, so that to ensure that there is a complete blink happening. Okay, instead of telling them blink 20 times, now how complete the blink is, you cannot judge. So it's better to ask them to close their eyes. So that's a simple blink exercise that I recommend.
Okay, thank you, ma'am.
We have two questions in chat box.
Okay.
So question one is, can we prescribe omega-3 to every dry eye patients, and what will be the dose?
Sorry, can you read slowly? I can't see the chat box for some reason.
Can we prescribe omega-3 to all dry eye patients? And
No.
dose this.
So omega 3 is good when there is a lipid layer thickness is less, and when there is the tear breakup time is also less because of quicker evaporation. In those cases, omega 3 work well. So again, the type of dry eye is very important. We no longer classify them as just an aqueous deficient dry eye or evaporative dry eye. Most cases, are a mixture of both also. But which component of the tear film is having problem, that you need to identify. If it's a lipid layer that is deficient, then omega 3 definitely helps much better.
And the second question is, ma'am, can we do tear film assessment without staining, and how?
So tear film staining, I would definitely recommend. So how will you just diagnose without staining? Is just first you run a questionnaire. You will know that the patient is symptomatic or not. If the patient is not symptomatic, then that person does not have dry eye. It could be some other ocular surface condition. First and foremost. Next, I would prefer doing an tear breakup time because in the university setting I do not have a fancy gadget for doing it non-invasively. I use fluorescein, and the cutoff is again 5 seconds. So that is, so without fluorescein is a big challenge. Okay, fluorescein is required for your tear breakup time. So if you do not have usage of fluorescein, then you need to have a mebographer or any equipment for dry eye assessment diagnostics. So not using of fluorescein is not a recommended norm. That's the least that we can use. Fluorescein and lissamine cream should be generously used in our clinics to assess. You will miss out on corneal epithelial staining, conjunctival staining, lid viper region staining. All of it will be missed. Otherwise, you can just do a tear breakup time. But again, how will you do tear breakup time without fluorescein? You should be having a non-invasive tear breakup time assessment equipment. If you have that, then I think you can assess more things like tear meniscus height and the meibomium gland assessment. All this can be done.
Excuse me, ma'am. Good evening.
Yeah. Good evening.
Ma'am, there was a slide where you mentioned about the lissamine green staining, and one more picture was there for the conjunctival. There was a beam, parallel pipe beam. Could you explain that, please?
So that is lid parallel conjunctival folds. that is also a marker seen in moderate to severe cases of dry eye. Okay, there is a desiccation. The reason why they become folded is because it loses the wetness in it. There is dryness because of the desiccation. All these there is the conjunctival epithelium layer becomes too loose that it kind of bunches up at the lid margin region. So because of gravity, the conjunctival epithelium kind of folds, and those folds bunch up near the lid margin. That is where you need to observe for lid parallel conjunctival folds. It doesn't require any staining. You can just watch it under the slit lamp with a white light and little moderate magnification itself.
Okay, thank you, ma'am.
Any other question? I hope the session was useful to all of them who have joined us today.
Yes, ma'am. Yes, ma'am.
No, ma'am, no more questions.
Okay. I
Thank
I
you so
thank
much, ma'am.
everyone